Yes, computer. Okay, welcome everybody to our Friday, November 27th meeting. I'm going to call the meeting to order and ask if anyone has a provision for disclosure of pecuniary interest. Seeing none, I'm going to move on to action items B1. I think what you have in front of you is an overview of the budget, a very high level overview. I've suggested a few changes to the wording of the resolution. I know we're not there yet, but I've suggested that we add the amount in, and instead of calling it budget, we call it estimates. The reason being is that we don't know the revenues yet, and sometimes that's often misinterpreted. When you say budget, that the revenue numbers that are in there are just estimates. They're not to be counted upon because we don't know them. So those are the two little changes, and Kathy will read that when the time comes, but Cindy's provided us with the very high level numbers. Cindy, is there anything you want to say about this?
Through the chair, no, we talked about this on Monday and Wednesday, so I believe that this is a good overview of our discussions.
And the number hasn't changed at all from in the last 2 days. It's the same one, right?
Through the chair, correct.
Yeah. Okay. So questions about anything related to do with the budget, where our goal today is to get to that resolution. But if there's something you want to dig into more, then we're happy to do that as well. And we have as much time as we need to do that. Is there anything from the board members that you want to ask more about the budget, or do we want to move forward with approving it? Okay. Curtis.
I don't have any additional questions. I just want to say that I think we had a good fulsome discussion on Wednesday about the budget. And with that, I don't have any additional questions. So if we do need a motion, then I'll be happy to move that.
Okay, seconded by, don't all jump at once. Oh, Brian, okay, good, thank you. Stephen, did you have a question?
Just a quick one. We have a report a little bit further down about the offload nurse program. I didn't quite have a chance, I didn't think to ask this the other day, but in terms of the balance, and I recognize philosophically having ambulance services funding directly the offload nurse program might not be the desired outcome, but it might have, on a dollar for dollar impact, might have the most impact in terms of unit hour utilization and offload delays, which are the key pressures on the service. That's so it's been presented. Had there ever been any contemplation of doing the investment from the ambulance core budget, and perhaps it's not even allowed under the ministry rules, to do a supplementation of the offload delay nurse program beyond that which is being funded directly by the MOHLTC.
Okay.
It's not even, it's just the MOH now. Drop the LTC part.
Yeah, that's true.
Yeah, anyway, 3 years.
So, no, that's a great question. We have a long history of thinking through offload delay nurse program. So Neil, why don't you, there's a lot to unpack there actually. Why don't you just get started and we'll go from there.
So, Mr. Chair, Stephen, so the funding envelope itself is, you may be aware of, it's 100% funded and it's outside of the land ambulance grant, which is discretionary. So this is on a year-to-year basis, and it's basically, again, mandated or through this program, which is from the originally developed for the nursing secretariat. So there are no plans that I'm aware of at this time from my provincial discussions that it's going to change the way it is currently funded. However, the ministry has been contemplating for a couple of years of moving away from the program itself as it is now to more of a pay for results, which is within the hospital, or P4R as it's known, to hold hospitals more accountable on their performance with regards to offloads and improving them. So in other words, hospital does well, they'll get incented financially, and if they do poorly, they will then get, I guess, penalized financially as well through a recovery by the ministry. That's one of the areas that's been looked at, but they certainly, the program's almost, I think, 11 years old now, and it was only meant to be temporary. So that's the latest that I'm aware of.
But the question related to what if we wanted to subsidize that program more? And I think there's been challenges just operating that. Like, first of all, we don't operate the program, but if we wanted to go to the hospital and say, we'll pay you more to get more nursing, I think was where Stephen was going with this question. So do you want to just touch on that and just how difficult it is to do that?
Well, again, we've asked under this program for 100% funding in past years to go from 16 hours to 24 hours. It's been denied. And the $16 million provincial funding envelope has been held for the last 3 years at that amount. No expansions, no increases in the hourly rate, no nothing. Certainly, I guess if a municipality wanted to go outside, that would be at their risk to fund that. But my encouragement would be to continue on at the 100% funding and to pressure the government to expand the program.
That's for you, Mr. Chair. Thank you, Chief Roberts. The point of this really, and the question is, if we were to spend $100,000 or say $500,000 of ambulance service money on paramedics versus $500,000 in the offload program, the bottleneck component where most of the system pressures are coming from ends up being in the availability of resources on the road, because ambulances are stuck in the hospital. So if we're putting more ambulances on the road to counter the offload problem, where we have a 2 staff member per patient ratio, whereas in the hospital, I think the offload nurse program is 1 nurse per 4 patients roughly, then that ends up being like an 8-time multiplier and more economically advantageous, and at the same time has the ability to liberate locked-in ambulances that are stuck in offload delay. So that's why I recognize philosophically it might be a challenge for us to say, yeah, we should be funding healthcare programs in the hospital, because that's probably a big no-no. But it may have more impact than us putting upstream dollars in the ambulance service, because we end up just putting more resources upstream that end up all getting locked into the bottleneck. And in just process analysis philosophy is to take a look at where the bottlenecks are and add resources to the bottleneck, rather than add resources where there isn't the bottleneck itself.
I don't know if there's anything you wanted to add to it, Neil. I mean, I know we've had trouble just even, I guess my experience is at least 8 years on the program or something like that. And I know at times we've had trouble just staffing the one position, and we've had trouble ensuring that the position stays with offload delay and doesn't get drawn into other parts of the hospital. So yeah, it's hard to know whether we'd be putting money into a black hole there. But I think it's something maybe we can take away and come back with a few more details on, and maybe Mike wants to give you some right now.
Thank you, through the chair. One of the things that, so I totally understand that, and I think one of the things that we've found, one of the challenges with the offload nurse program specifically, is that there are limitations to that program, specifically things like patients requiring cardiac monitoring, which is determined by the LSPCS, as you know, through the base hospital system. So patients who require cardiac monitoring, who've received certain medications, don't meet the criteria set by the hospital to fit the offload nursing programs. And so while it's a potential idea, it would require us to go back and do some policy revisions that would take a bit more work with the ministry and with the hospital. So I guess that's one of the challenges we see, is a lot of paramedics still end up stuck in offload because of, even if there's an available offload nurse bed, but because of treatments they've received or treatments they still require from the paramedics, that the hospital can't continue in those stretchers in the hallway. The other thing that I would just point out too is that we added, the board is familiar with our Fit to Sit program. And that was another program we implemented last year as an attempt to try to come up with another way to offload our staff for those low acuity patients. So the Fit to Sit program, which I'd be happy to discuss in further detail if you wish. But it's a program designed to target specific patients through specific criteria to go to the waiting room, which helped offload a fairly reasonable number of our staff. And we actually are probably due, to be honest, probably at the next board meeting to update the numbers through that pilot. But we did see some quite promising results through our initial report of offload hours. But just two areas just to add to that sort of bigger problem complex issue.
Okay, Stephen, go ahead.
Yes, through you, Mr. Chair. Thank you, Deputy Chief. And thank you, Chief, both for the answers. I recognize at this point in the process, it doesn't make a lot of sense to try and look for alternative service delivery models. However, there is an opportunity that comes up with the master plan review. And I think that's a good opportunity to try and figure out, there's going to be some nuances associated with this. One is whether the cost shared dollars that are provided to the municipalities to run ambulance services can be allocated in such a way that provides some funding agreements or some labor agreements with the hospital in order to address the offload delay problem itself. The second is going to be some collective agreement issues, both at the hospital and in the ambulance service. I totally recognize that. It's not a very straightforward process. Identifying protocols as well is going to be a base hospital issue. It's a really tough knot to untie. However, I think the service demand and resource availability concerns are really focused in that one area. We're absolutely going to see a continued increase in demand, probably in the 8 to 10% range each year. But in terms of the hours consumption, when you take a look at the reports that we've been given, it's just massive amounts of hours that are being consumed in the hospitals. And it's good to see innovative programs like Fit to Sit and that the offload delay nurse at least has been continued to be funded, even if they haven't put inflationary dollars into it. At least there's something there. Those are part and parcel. And I know strategically you're looking at other things like diversion protocols and opportunities like that. So I raise that more for we have a good opportunity coming up as we move into the master planning. And I think that really needs to be a core area of focus within that master plan to look for alternatives to address specifically that bottleneck.
Yeah, for sure, because that's one of the major cost drivers and cost bottlenecks. So it's likely going to be an area that we have as an area of focus, even though it's not under our control. What policies, what procedures, what can be done to improve that bottleneck is certainly going to be something we're going to look at. So I think that's a worthy place, a worthy suggestion. We'll add that to the list of things that need to be looked at. Kathy?
Yeah, no, I was had made the note of the master plan while you were speaking, Stephen, so I'm glad that you raised that. You know, I've been involved in having discussions, you know, representing the county as well as paramedic services with the chief over the last few years, discussing this program with LHSC. And, you know, I always like to be, you know, Pollyanna, and always hope that, you know, something positive is going to happen. It's been difficult conversations, and what we really need is, you know, an advocate on their side of the table as well for the program. And if we can find that, then I think the program, you know, could likely be more successful. I'm never going to give up on trying to better it and strengthen that through discussions with LHSC. But I do think that if it's in the master plan, then at least it becomes a strategic priority and holds us a little bit more feet to the fire on that one.
Okay, good. Thanks for everybody's input on that. We did have a mover and a seconder, right? We had Kathy, we had Curtis and
Brian.
Brian, thank you. Yeah, there he is. Is there anything else on the, do you want to read the resolution as it reads now, Kathy, just so everybody's clear?
Sure. that the draft 2021 estimates for the Middlesex London Emergency Medical Services Authority operating as Middlesex London Paramedic Services in the amount of $46,864,128 be approved as presented, forwarded to the Middlesex County Budget Committee, and then that the City of London be advised of their portion.
Okay. All right. Moved by Curtis, seconded by Brian. All those in,
Just
Kathy, sorry.
one quick question. And the City of London is then advised after it goes to
Yeah,
get approved at the county level, right? Okay.
Yeah.
Just wanna- okay.
agreed. Yeah. Okay. Oh, Stephen, go ahead.
Sorry, just to note that I'd imagine that the city is probably watching the proceedings on this and the information. So they'll recognizing it's not an approved budget, but recognizing that what's happening here is referring this to county for approval. That at least there's a placeholder for the city to be able to do its budgeting.
Yeah. And so that's the other thing. We're just setting up, actually, it's going to be in the next 2 weeks. I just don't know when, but there's a management oversight committee meeting with the city to go through the budget with them. So it'll be Neil and Cindy and myself, and then on their side, it's you know, the finance people, Annalisa, Kyle, and I think that's, well, and of course, Lynn will be there. And so anyways, the purpose of that is to go through all the pressures and talk about those type of things they need to educate their budget. And then as we get new pieces of information, whether that be provincial or approval from county council or whatever, we update them at that time. So that's the process. So, okay. All those in favor? Opposed, if any? It's carried. All right. Thank you for your work on that and for all your great questions. I do have another thing I want to get to quickly today, just a new news release about community paramedicine, but Neil, I think we'll get that maybe down under new business. And right now we'll move forward with the First Watch Fat Pot. So who's taking that? I guess it's not Neil because he just left the room. Is it you, Adam? Are you the lucky one?
Yes, I'll be discussing First Watch and Fat Pot.
Okay, thank you.
So to provide some background, our service has been using the program Fat Pot to provide situational awareness of the system as a whole. It shows the calls that are ongoing and their location so that we can monitor the number of resources that we have that are dedicated to calls so we can better see how the system is actually handling and able to flex. That particular software is no longer being supported. In the interim, when we were given the notice that the software wouldn't be supported any further, we had already been engaged with First Watch. First Watch, we worked with them along with the Ministry of Health and the London CAC, and we're able to create a lot more efficiencies within the First Watch program that allows us to effectively replace what we were using Fat Pot for. First Watch is a really powerful analytics program that allows us to not only monitor our system, but then we can actually delve into some of the data and the drivers that led to those calls and where they were, how they increase, and as we move forward. So we have some information through some slides to show exactly what this system is going to look like. Kathy, put those up.
Did you get those, Bill?
Okay. Did
You
I
have
get the?
control of the meeting. I can't put them up.
Yeah, but I didn't have control of the slides. I don't know what you're talking about. So
They should be in your email from Marcia, maybe, or Adam.
well, while
Marcia
I find
forwarded them.
okay, while I find them, why don't we just have Neil talk briefly about the changes to the community paramedicine program, and I'll find them well, so we don't waste anybody's time.
Thanks, Bill. So through you, Mr. Chair, to the board. So about a week or 2 weeks ago, Minister of Long-Term Care, the Honorable Mary Lee Fullerton, announced a pilot program for community paramedics to assist with long-term care waiting lists in the province through remote patient monitoring and basically keeping patients that were hoping to move into long-term care more in the community to adjust some of the long-term waiting lists themselves. And today the province announced the opportunity for services throughout Ontario to apply to access this funds. So when the minister announced this 2 weeks ago, she announced initial Renfrew County, Ottawa, York Region, Brant County, and I believe it was a service Cochrane up north, each receiving $1 million annually in funding to provide 24/7 community paramedics. So now they're expanding it throughout the province and have opened it up to the other community paramedicine programs that were established under the original program itself to potentially apply. So it's late breaking. It literally came out about 2 minutes ago. And we'll send that on to Kathy while the board meeting is underway, and she can distribute that out as well.
Okay, thanks, Neil, for that. I have your slides ready. Adam, you'll probably see your screen go right now.
Perfect.
But I don't know how well they're able to see that. Maybe this is better. Is that better?
That's perfect.
Oh,
Yep.
Okay, good.
So what we're looking at here is the main screen that would show the ongoing call. So this is what we're able to use to largely replace FatPot. This shows all of the calls that are ongoing. And having worked with the Ministry of Health and the London Ambulance Communication Center, we were able to actually now bring in calls that were being held. So we were able to build efficiencies on what the FatPot program was able to show. So in real time, we can see the number of units that were actually assigned on calls, and we can see where they are based on the timings throughout the system. In this particular one, all of the personal identifiers have been removed. So the superintendents would actually be able to see the addresses so that they would be able to respond to a call if there was a need for assistance or supervisory needs on that particular scene. We're able to go in and bring up any of the information that would be in the computer-aided dispatch system, so we could see call details if we needed to be able to provide more insight or we needed to review a call.
Is this one?
This dashboard here now provides the supervisors and the superintendents a real-time snapshot of actually what's going on in our system at any given moment. So whereas the previous screen showed us the ongoing calls, this particular one shows all of the units that are rostered into the system at any given time. It shows their start times, their end times, the total number of calls that they've been engaged on, the total number of patients they've transported, and a cumulative total of the time that they've been assigned to calls, so that we can actually track UHU down to the individual units. So it gives us the ability to see how busy each of the trucks are throughout the day, so we can make sure that we monitor so that crews are getting their breaks, that particular units aren't being overtaxed. And then as the day starts to progress towards the end of their shift, they'll start to be highlighted based on their end time, so that we can start looking to make sure that if units are engaged on the other side of the city from where they need to be to come off shift, we can start rotating our units through the system to bring crews back towards the central headquarters for their end of shift. So this will help us get crews off on time, helps reduce overtime. It helps make sure that crews are rested. And this dashboard here is a hospital status dashboard. So we're able to see exactly the number of units that are at any given emerge at any given time, as well as the time they arrived, the time and their total time, and we can see the elapsed times that the units have been there. So this really is important when we're monitoring offload delays. So we can see the individual units, the two screens that drop below the main dash. So broken down into each individual emerge, we can see each of the individual calls. So if a unit was on offload delay for a longer period of time, we'd be able to go and take a look at it and we'd be able to see that. So if we're looking at a max time or an elapsed time, we can see if it's one particular call that's been the reason why that crew's been there for a long period of time, or if one emerge is starting to struggle. And that also helps the supervisors make sure that units are dispersed between the two hospitals so we can better manage the system. So together, these three dashboards become really important and become an extremely useful tool. And because they're in First Watch, all of that information is available to us later for detailed analytics when we're looking to how we're going to deploy resources in the future so that we can maximize everything that we have.
Okay. Questions for Adam? Stephen, go ahead.
Thank you, Mr. Chair. Thank you, Mr. Bennett. These are exciting because I brought First Watch into Oxford about 10 years ago, maybe 15 years, or yeah, probably about 10 years ago, I think.
You were going to date yourself a bit there.
Oh, yeah. Well. It starts to realize the power of the software. Back then, we weren't able to have access to the CAD data. We just grabbed the data from ACRs. And so the CAD data gives the ability to get that real-time and real-time information, which really helps from an operational picture. The province having wound down support for FatPot, and it sounded like you needed to do a lot of kind of one-off individual work with CAC and the province to be able to have access to these feeds. Was there a product that the province ended up providing support for in the end, or did they just open up access to the SQL database so that you could grab extracts from the places that you need to? It seems like a fairly complicated thing. The reason I'm asking this too is further to get towards the idea of real-time computer dispatch and transmitting information directly to the terminals in the trucks. Because if that's what you're getting off of this, then it seems like that's the next logical step to being able to dispatch directly on a computer basis.
Yeah, so through the chair, we were able to access information through the CAD before. So they funneled their information through another program called the KIP, and we were always tied into the KIP. But what we worked with, so the information that we were available to get through the KIP was pretty much the same information that we were seeing through FatPot. What we worked with the ministry and CAC to get access to was all of the information, or the call information, when it is geo-validated in our area. So FatPot would show any call that a unit had been assigned to, but in periods where there was a huge call surge, or when we're looking at code zeros, there could potentially be calls that are sitting in the CAD that have yet to be assigned to a crew, and we would be blind to those. So we worked with them to get access to that specific field within their SQL database fed to the KIP, so that we can actually see that now. So when we're looking at First Watch, we'll see that the call is sitting there, but it won't have an assigned time. So we know that the call is yet to be assigned to a unit. So we saw that as a huge benefit, so that we can actually see those units now, and we can see if there's additional units within the system, within our system, that are aiding. So we're actually able to better monitor what's going on now.
Okay, Neil, you wanted to pipe in on this, I think, or did that cover it off?
A bit. So for you, Mr. Chair, Stephen, so one of the other areas as well I think you're asking about is the ability to take the CAD data and bring it into the front of the vehicle. And so we've been working with the ministry, and in fact, your question is timely, as we have a meeting today with the Assistant Deputy Minister and the IT cluster on trying to move ahead with Marvelous into the front of our vehicles. Because there is a bi-directional feed with dispatch, and we've been trying to harness that. And our position provincially has always been is that the ministry needs to be agnostics, in other words, flow the data and let the service determine which vendor and which software solution they want to work with. So we hopefully will be able to give the board an update after today's meeting if we're successful.
Okay, Stephen?
Yeah, through you, Mr. Chair. Thank you, Chief. Thank you, Commander. Both of those are very helpful, and you touched on what the next question was going to be, was Marvelous, because it seems to set up nicely, marvelously for Marvelous.
Yes, it is.
It's a better name than FatPot. Brian?
Yeah, thank you, Chair. I think that pretty much actually answered my question was, is this a step in the right, a large step in the right direction, or is this our ultimate? And I think by what you're saying, this is just a large step going forward to get where we want to be, right?
Yes.
Okay. Anything else on item 2 and it says action items, but you're just receiving it for information, right, Kathy? Okay, I don't see any other questions on this item. Could I get a mover and a seconder for just receiving this for information? Moved by Kathy, seconded by Stephen. All those in favor? Opposed? It's carried. Okay, perfect. And we're moving on then to correspondence and information items. The offload nurse agreement. Neil, do you want to talk about this, please?
Thank you, Mr. Chair. So just briefly to the board. So this funding envelope is provided on an annual basis. We did receive our funding, and I believe as part of the package is the report that went through to Council on November the 10th. The document's been executed by the ward and the county clerk. It is currently with London Health Sciences awaiting execution, and we hope to have it back. The period for the funding is from April 1st, 2020 to March 31st, 21. The amount is the same. The hours are the same at each site, 16 hours at UH, 16 hours at Victoria. And so really there's not much of a change, but we just wanted to make sure that this board was aware of that agreement and that funding envelope. Thank you.
Questions about that one? I don't think there are. So I'm gonna move on to COVID screening. And Adam, do you want to talk about this report?
Be glad to.
This isn't one that I'm supposed to have slides for too, is it? Just give me.
There is.
No. Oh no, Kathy, did you send me slides on this too?
They're in the package, Mr. Chair.
I know, but I didn't know if I'm supposed to be putting them up on the screen and have the original ones. I guess I could go from the ones in the package, but okay, that's good. You guys can handle it from here. I don't have to put them up on the screen, right, Adam?
No, I can just talk about them then if everybody has an
Perfect.
impact.
Yeah.
So when we're looking at the first slide in the package, what it's showing is we looked at, and a lot of this data we actually were able to pull through First Watch. So we were tracking since the start of COVID. We were tracking the number of incidents in which the dispatch center coded the patient so that they had failed their COVID-19 screening. And then we also compared that data with the number of times that the paramedic showed up on scene and conducted their screening and had a patient fail. So within a period of March 1st through November 1st, there were 78,000 incidents in which the patient failed the screening through the dispatch center, and then 43,600 in which the patient failed with the paramedic. So we can see that there was a large difference, but we also see how the numbers were starting to go up. So when we look at the number of incidents per week that somebody had failed their screening, we could see the dramatic increases as we moved through the initial stage of COVID to the number of failed screenings that we saw as we started moving through the first wave, and where we're sitting at now, being right now within the last few weeks, we're at the highest number of failures as far as the screenings go. And then the second slide gets a little more granular into the reasons for their failed screenings and the chief complaints of the initial 911 call. And by far the largest precursor to the 911 call was breathing problems. And then we can look at the geographic locations, the City of London taking up the largest response area, followed by Strathroy.
Okay. Questions on this before I take them down? I guess I can't see everybody. Oh, Stephen, you had a question?
Yeah, thanks. I'd imagine probably this is reflective of the total number of shortness of breath calls that you have, and almost all the shortness of breath calls are going to screen as negative or positive on the screen, just by nature of new or worsening shortness of breath, right? So,
That's correct.
You want that one, Adam?
Sure. So through the chair, yes, I agree with everything that you've said, that in when we're looking at the shortness of breath and the triaging that goes there, I think the fact that we have such a high rate of failed screenings by the paramedics when they show up to the scene shows that they're actively using the screening tools, and then they're donning their appropriate PPE. So when you compare that with the number of actual COVID positive patients that we have in the community, even as a whole, and then a smaller portion being those that paramedics would have even potentially come in contact with, shows that even though the pandemic's been going on for so long, that our staff are still being really diligent in their screening and their use of the protective equipment. So I think that's very positive.
Good news. Thank you.
Okay, anybody else on this one? Okay, so there's a motion there that item C1 and C2 be received for information. Can I get a mover for that? Brian's moving it and seconded by Stephen. All those in favor? Opposed, and it's carried. Okay, so I'm down to inquiries. Neil, you've talked a little bit about the expanding program. We'll get that, the expanding community paramedicine program. I have done a little bit of work on having a community paramedicine webinar format to talk about it and to encourage it. So I'm targeting January for that. And so we'll get some more details out to the board about what that might look like and get your comments on it. But were there any questions on what Neil's been talking about in terms of expanding the program? And is there anything else you want to add, Neil?
The only other thing as well is that there is another potential funding, I guess, pot that is currently under review by the government, and that was when the Premier directed Matt Anderson, the CEO of Ontario Health, to look at sustainable funding for community paramedic programs in all 59 paramedic services around the province. That proposal was created by the Ontario Association of Paramedic Chiefs, was delivered to Ontario Health, and my understanding is in turn it was delivered to the Premier's office and Minister Elliott's office, and is working its way through the approval chains. So there also may be another pot of money as well on community paramedics. So stay tuned on that.
Okay, and I'm sure we'll get you this press release out soon if you haven't already seen it. Any questions on that item? Community paramedicine, none. Neil, I know at some point, just another little added item here. I wanted to just mention, I promised you that I would mention about the Management Oversight Committee. I'll probably send you a copy of this to see if there's anything on my proposed agenda that for the MOC that the authority thinks should be added, but I have on my agenda to provide an overview of call volume statistics, offload delay analysis, the 2021 budget, facilities update, operational review plan, community projects. So those are new items that are being done in the community by paramedic services. Oneida, development charges, joint provincial pressure opportunities, and real-time information sharing opportunities as we go forward. So that's my agenda items for the meeting with the staff at the city. And yep, Stephen?
Might I suggest as well having a discussion about assessment growth funding? I think
Assessment funding.
assessment growth funding. So the city, through assessment, where it realizes new revenues associated with assessment growth, is able to fund growth-related costs in subsequent years. Having those predictions, and I think the master plan will be really key to this. And so I think it would be good to raise in that discussion that the master plan is being done because and we do this with police and fire, for example, if we need to add a new fire station or we need to add new police officers as a result of growth of the population, then that's where an opportunity to put new ongoing funding into a base budget for a service comes into play. So we've been able to fund 6 or 12 new police officers through assessment growth rather than through the levy, through new base levy increases.
Yeah.
To date, the paramedic service hasn't been able to take advantage of that. It would be important to know how that could be done, because I think probably one of the biggest concerns you hear from the municipality is what that levy impact ends up being at the City of London. Rather than these costs are quite reasonable, we would see that that the service needs to expand as population expands. The call volume growth increases much faster than population growth. I mean, call volume growth in an 8 to 10% area, population growth is about 1 to 2% area, but at least a portion of the growth could be accommodated through potentially through assessment growth. So if that's an area of discussion, I think it's helpful and might help us further here at the board.
Yeah, very good. And the other one that I clearly forgot now that I look back on it is also the one you mentioned the other day about planning and site and getting what's the term you used for the process that you use there?
So there's a draft plan of subdivision, which typically takes a look at whether there's any land needs associated with schools, fire stations, public services in any way. And those are usually circulated to the agencies for review to determine if there's a planned need for any of those facilities within that area in the coming future.
Yeah, perfect. So I'll put that on the list as well, but I'll send you a draft copy of this later today once I update it and see if there's any other suggestions that you have. But that's going to be a long discussion because there's so many topics there. But we're trying to get that done. I was just reading Lynn's email. And we're trying to get that done before the 10th of December. So we'll get there. Okay, anything else you can think of? Neil, were you going to give an update on where we are with Oneida at some point, or is this not an appropriate time for that, or is it?
I still need to have a follow-up meeting with the CEO of Oneida.
Okay.
Of operations, so to better understand the path going forward.
Okay. So hopefully that happens soon and we can communicate that out to the board where we are with that. And it'd be also good if it happened before our meeting with the MOC so we could communicate that to my colleagues at the city. Okay, so I think that's it. Are there any other type of inquiries / new business type of things you want to raise here before I let you go? Okay, so next new business, next meetings are, I guess that's at the call of the chair. There's just a nice title there, Kathy. A bylaw to confirm the proceedings. Oh my goodness. Okay, so that's a confirming bylaw. Can we get a mover and a seconder for the first reading and second reading? Curtis and Stephen, okay, great. All those in favor of that? That's approved. Third and final reading of the confirming bylaw. Brian and Kathy, and anybody opposed to that? We're all in favor of that. Okay. Perfect. Now I need, without further ado, I think we actually 11 minutes under our target today. So that's great. I really appreciate everyone's indulgence this week. I know it was a lot. I know it was a lot in a short period of time, but we managed to, through emails and text messages and meetings, communicate our way to a good solution here and a good outcome. So everyone appreciates your time commitment. And without further ado, a mover and a seconder for adjournment, Kathy and Stephen. Perfect. All right, all those in favor? Let's carry.